So there's one additional question, and that's what we're going to get to next. So I think we've clearly seen the value of this test in this patient that's been through 5 years of endocrine therapy and is facing this important decision. We have something that, in my view, is a standard of care decision-making tool and can be incorporated for those patients. However, this is an interesting molecular diagnostic that's really interrogating that micrometastatic niche in terms of its endocrine sensitivity and its inflammatory nature, and that's what that ratio really is telling us. And so the question then naturally that can be asked is, what's that going to play out like in an earlier stage setting? And of course, you want to study this in the context of something that's potentially very high risk. So that's young women who are at risk for early recurrences. And we have now data showing us in that setting that ovarian function suppression, in addition to endocrine therapy, whether that's tamoxifen or aromatase inhibitors such as exemestane, can be helpful. So what is this biomarker going to inform us about that in that setting? So this is, of course, presented last year at this meeting. Lots of attention to this by Ruth O'Regan. And I just wanted to go through that data, having reflected on it for about a year now, about what that kind of looks like. Now, I will warn you that this data is hypothesis generating right now. We do need to validate it a bit more. So if this is a drug talk, we would talk about on-label, off-label. So everything we talked to about up to this point was, quote, on-label, about how we actually use it. And now this is that future state of what might this look like as more data accrues. So we'll talk about the SOFT trial first, kind of set up and remind everybody of what that was. And then we'll go through the biomarker analysis through the translational cohort. So SOFT was a very large trial. By itself had greater than 3,000 patients. These are early breast cancer patients with hormone receptor positive disease, and they were premenopausal after chemotherapy, or premenopausal and never received chemotherapy, and were then randomized in this interesting way, 1 to 1 to 1, where the standard of care at the time for those women was to get tamoxifen, and then the randomization was to add ovarian function suppression with tamoxifen or ovarian function suppression with exemestane. Here going forward, I'm just going to say OFS. And looking at the stratification of those patients, about half received chemotherapy and half did not. And the bottom line from that, and we have now lots of follow-up, at 12 years of median follow-up, there's about a 3% difference for distant recurrence. That was not the primary endpoint of the study, but looking at the thing that we as medical oncologists are really worried about, late distant recurrences, that number was 3% better with exemestane and ovarian OFS versus TAM alone, which is a control arm, highly statistically significant. And overall, when you compare the exemestane and OFS versus TAM versus OFS, 1.3% versus 1.4%. So both did improve, and they do look modest, right? But they're impactful for this patient group. So patients who may currently be considered for ovarian function suppression, this is a bit of a clinical decision right now. There are things in the study that really did come out: young age, high grade, lymph nodes, and that's what's on the NCCN guidelines. In addition, there have been additional post hoc analyses performed. So there's something called a STEP analysis that was published a few years ago in early 2020 in the pandemic. I don't know if everybody got to read that paper, but in that paper, they looked at clinical factors that might predict. And they created a scoring system of sorts. So for example, a patient that was very young, 35, had nodes positive, might have received chemotherapy, those patients are very likely to benefit from ovarian function suppression, OFS, plus exemestane, as an example. But wouldn't it be nice if we had a genomic marker that can inform us on that rather than the clinical? In many other contexts, the genomic markers have really outperformed the clinical markers, including in the extended adjuvant setting. So this is the sort of unmet need that we could do this. So that was, of course, performed in SOFT. And in that biomarker cohort, there was 1,717 patients. 30 didn't have enough DNA, and at the end of the day, the final cohort was 1,687 patients where this could be looked at. The primary outcome for the biomarker cohort was to look at whether or not the H/I biomarker predicted benefit from escalation with exemestane and OFS versus TAM alone. A secondary endpoint looking at that same question with tamoxifen instead of exemestane. And then additional study endpoints, or notes to note, is that the endpoint was breast cancer-free interval, and BCFI is a composite endpoint that includes invasive, local, regional, distant, contralateral events, and looks for that in the predictive analysis. So first of all, when you look at the first panel on the left, that's the overall cohort from the biomarker enriched cohort. It honestly looks just like the main paper. Not a big difference. The 3 arms play out the same way, showing that there's benefit from the escalation all the way to exemestane plus OFS compared to TAM alone, with the other arm in between. However, when we broke out the cases based on the biomarker, an interesting signal emerges. So in the patients who had an H over I high score, remember that means endocrine sensitive cancers, just giving endocrine therapy alone with tamoxifen was equivalent to escalating with exemestane and ovarian function suppression. So no difference there. However, in the cancers that we now, but from this biomarker, understand to be less endocrine sensitive in those microenvironments, that's where the impact of escalating made a difference. So when you look at this, exemestane plus ovarian function suppression had almost a 12% difference between the tamoxifen alone arm, and in between that was the tamoxifen and OFS versus the TAM arm. So some study conclusions based on this. The BCI translational cohort was representative of the soft cohort. It wasn't cherry-picked. It was nicely represented. And then in the recent evaluation within that cohort, we kind of get a hint at who might be benefiting from OFS, not just based on clinical factors, but now on a molecular feature. And that low group consistently derived benefit in a meaningful way from OFS, while BCI-HI over I group did not. And so this is kind of an interesting, where are we heading with this? So just putting that into practice, or can we put that into practice? I think it's still early. We want to basically repeat this experiment in the same way that BCI was repeated for many, many trials in the extended adjuvant setting. We want to feel confident that this is a biomarker that can help in this way. I know personally that this company that has developed this assay is actually trying to do that right now. But we want to make sure we validate that properly before putting it into play. I do think that the biomarker is still telling us a very consistent signal about what's happening in that microenvironment. So this is just exciting news. I think that's on its way.